Dr. Suresh.
As Rahul.
Yeah. I just wanted to know if I am audible. My sound is okay.
Yeah, sound is very clear.
Very clear. Okay, thank you. I will just try sharing my screen also. Just a minute.
Okay.
So that we get the technical stuff done away with.
Yes. That is better.
Than fumbling with that in the last moment.
Yes, that's true.
Yeah.
Better.
Let me try.
Okay. Fine.
Just a minute.
Am I audible?
Yes, you are.
Yes, okay.
So
Fine.
let me share the screen. Where is that PowerPoint? But is it visible in full screen? I don't think.
Yes. It is not slides.
No. Now it is full screen.
Now it is full screen. Okay.
Now it is moving.
It's moving.
And are you able to see my cursor moving? Now it is over the word the patience.
Cursor is also moving. Yes.
Cursor is moving. Okay. Thank you. I think then the system is working. Thank you. I will stop sharing and we will wait for the rest of the proceedings.
The other people.
Thank you.
Right. Okay.
Thank you.
Good evening, everybody. Hi, Dr. Sahul. Welcome.
Good evening, sir.
Good evening.
Tupanpati, sir. I'm Dr. Suresh.
Yeah, I know.
Yes, yes.
You are still on behind screen.
Oh, it is not yet open. No? Let the organizers come and Sahil has made its trial today. After that, he is muted, I think.
I think you'll be joining in the meantime. When he joins.
Thank you, sir.
Lot of people
Doctor. Yeah. Thank you, everyone, for joining. Welcome to the 111th edition. Today's topic is I drank against CBT for frequently relapsing alcohol patients. Now, we have a very perfect speaker for the topic. We all know him, so he'll be introduced later on. The rules of the game would be that everyone will be on the mute mode. The panelists can unmute themselves. The questions can be shared in the chat box. The moderators will put the questions to the speaker. Next slide, please. Let me hand over the program to Professor Dr. Tufan Pati sir. Sir is from Cuttack. He has ample experience, a lot of organizational experience. Sir, over to you, not wasting time.
Thank you, Alim. And good evening, everybody, and welcome to this 111th episode of Thirsty Musings 111. In picture, it looks like 3 wickets. And we have crossed that border. And let me introduce to you the vibrant moderators who have been there in Thirsty Musings since the beginning. Let me introduce Dr. Alim Siddiqui, Dr. Amrit Pattodosi Bhubaneswar. He is a professor and chief consultant neuropsychiatrist in High Tech Medical College. He is a direct EC member of IPS and he is the president of IPS Odisha, president-elect of IPS Odisha State Fund and secretary of IPS Eastern Zone. Next slide, please. Dr. Alim Siddiqui, professor of psychiatry in ERAS Lucknow Medical College and currently treasurer of Indian Psychiatric Society. And he had been a direct council member and he has got many tributes to his great. And Dr. Siddiqui and Dr. Pattodosi are the moderators from the beginning, vibrant IPS members and moderators today. Next slide, please. Our chairperson, Dr. Z. Suresh Kumar from Visakhapatnam. He is MD, DPM, DNB in Psychiatry and MBA HRM. And he is professor of psychiatry in Andhra Medical College in Visakhapatnam. He is an alumnus of Andhra Medical College and he is DNB Psychiatry from National Board of Examinations. His MBA HRM from Andhra University. He is past president of IPS Andhra Pradesh State Branch, honorary general secretary of IPS South Zone, IPS Southern representative for National IPS, and IPS Andhra Pradesh representative to South Zone. He is vice president of Vishakha Psychiatric Society, and his areas of interest is de-addiction. In de-addiction is rehabilitation. Welcome, Dr. Suresh. Next, please. Now, we are happy that we have Dr. Arvind Bharat from Jodhpur with us. Welcome, Dr. Arvind. And
Thank you, sir.
He's a senior consultant psychiatrist in Jodhpur. He has more than 15 years of experience in psychiatry. Common consultant at Psychiatric Center, SMS Medical College, Jaipur. MBBS from SMS Medical College, Jaipur. And MD Psychiatry from SMS Medical College, Jaipur. The Premier Institute of Jaipur. He is treasurer of Indian Psychiatric Society, Rajasthan branch. Advisor Task Force on Stigma and Mental Health, Indian Psychiatric Society 2021. The chairperson Task Force Yoga, Meditation and Mental Health. Welcome, Dr. Bharat and Dr. Suresh. And from here onwards, please carry over the meeting. The stage belongs to you.
Thank you, sir.
Thank you, sir. Thank you. First of all, hello, am I
Yeah.
audible?
Yes, you are audible.
Thank you, sir. First of all, I'm very thankful to organizing team to introduce me as a chairperson of this Thursday meeting. And today is a very eminent speaker in our, that's Saul Amin. And he's the MD from CIP Ranchi, and is a consultant psychiatrist at the St. Thomas Hospital in Chengagiri, Kerala. He's the editor of Indian Journal of Psychological Medicine. It's a great thing. And he's the co-editor of a book. This is recently published. Is the primer of research, publication, and presentation. The very good books for newcomer psychiatrists, and have presented more than 200 articles regarding mental health in Malayalam and 56 publication and 71 Citizen and Google research. And he have wrote the e-books of the completion of fish psychopathology. And this fellow has got the best award of IPS in 2000 IAPP conference in 2013 that I have attended. This is I have no word for introducing himself because he's the eminent speaker in front of us. And today the topic is, sir, I drunk and again. This is CBT for relapse prevention. The topic is, can it helpful for us for the relapse prevention? Sir, alcohol is, as we know, the huge problem and huge burden in societal. And the impact in, there is a social impact, there is a legal impact, there is a physical impact, and a lot of has the impact in our society as well as in our life. So as we follow the treatment protocol and the patient in our clinic setting and on the maintenance treatment of alcohol dependence, and they are frequently relapses because the research studies that 90% of the patient is the relapse in first 3 months. This is the study. But what we can do, how we can help, and we can identify the such factor which is the really responsible for their relapses, they frequently reduce the abstinence period. So the CBT is definitely helpful, and Dr. Sahul Amin will elaborately discussion about these things. But as I understand, that the factor responsible for this the prevention of relapse of alcoholism patient. So we first identify what the trigger, what is the stress event, and what is the factor which is responsible, which is the derail the patient to drink the alcohol. So we identify the such, and we have learned the CBT phenomena, including the self-monitoring techniques, assertive training, refusal techniques, relaxation techniques, and these all are including in this. And we have learned a lot from Dr. Saul Amin. So without any wasting time, I'll invite Dr. Saul Amin to present this topic. I drunk.
Dr. Suresh, would you want to make some remark?
Yes, sir.
Opening,
Yes.
yeah.
Yes, sir. Because the Arvind Barad has took the introduction and the topic introduction. As Shahul is a good friend of mine, as we are both worked together in the South Zone. As I worked as a South Zone representative, he is working for the third time for the editor for South Zone in a prestigious journal. He came from from a prestigious institute of CIP Ranchi. He is very strict and very punctual, very methodical. He is in his presentations, in the way he all the present the in fact the way our South Zone journal stood at the high impact factor, and it is already with his Scopus category, and it is, and he has published many articles on his own in the weeklies and dailies. And he has the best his presentation at the annual conference IAPP in 2013. He presented many papers. He is a deputy editor of Indian Journal of Private Psychiatry. He was, and he also was IPS has recognized to attend the Young Health Professionals track at the International Congress of WPA held in Bucharest, Romania in 2015. He presents very crisp and very important, very the audience very. What is important to the audience, he will convey the message in such a way, the lucid presentation. I'll hear it from Sahul. Over to Sahul.
Let me share the screen. I hope the screen is visible in a full screen.
Yes.
Yes.
It's visible, quite
Okay.
visible.
Good evening, everyone, and thanks to the organizers and the chairpersons for the kind words, and thanks to all the participants who are here. Nearly 200 are there. All of you are here after a day's work. That shows that you are interested in this topic, and also your confidence in me. I hope that I will be able to live up to the expectations. I have 2-3 introductory remarks to make. Especially because of the time constraints, I will not be touching upon the basics, because I assume that this August audience knows the basics of CBT, how our thoughts, emotions, and behavior are related to each other, what is positive reinforcement, what is negative reinforcement, what is classical conditioning. So those kind of explanations I won't be giving. Secondly, whenever somebody speaks about therapy, there will be a lot of discussion about abstract topics, the philosophical aspects, the schools of thought, the controversies. I will not touch any of them, not because they are less important, but I am a clinician and most of you here are practicing clinicians. So basically, we will be covering only the practical tips that will help us in our day-to-day practice. Thirdly, though I am a journal editor, I will not discuss any statistics, p-values, effect size, scientific rigor, etc., simply because I want to keep matters simple and like understandable. And almost all the information that I am going to present here today is basically from this particular book by Marcantonio Spada, a CBT for problem drinking. This edition came in 2010. Recently, they have brought out a second edition. I don't have that. But if anybody wants to know more about this topic, this is a wonderful book. I strongly recommend it to all of you. So from a CBT perspective, how and why a lapse and a subsequent relapse happens? There are 2-3 mechanisms in play. One is mediated by classical conditioning, or it could be through operant conditioning, or it could be through cognitive mediation. So in this presentation, I will briefly touch upon classical conditioning and operant conditioning and how we can tackle such lapses and relapses. And also to some detail, we will discuss the cognitive mediation part. So let me start with the classical conditioning part. Many a time, classical conditioning can lead to craving. That is because their classical association has formed between the pleasure caused by alcohol and various other factors. Those factors could be external or internal. External cues could be, for example, some of your friends. Like you routinely drink with one of your friends. So even if after you have stopped drinking, suppose you meet that person or you see his photo or you even think about him, that classical conditioning association may cause a craving in you, leading to a relapse. Or the cues can also be internal. For example, suppose a person gets a headache, and whenever he gets headache, as a self-management, he drinks alcohol. So when that becomes a habit, whenever he gets a headache, he might get a craving because of the classical conditioning. So this is how classical conditioning can lead to craving and subsequent lapse and then a relapse. So what we can do here as an intervention for our patient, the main technique is stimulus control, like that is controlling the stimulus that is like causing this craving with this underlying classical conditioning. So how to do that? There are 2-3 major simple techniques. One is like avoidance. That is a simple one. For example, most of the time when we discharge the patients, we ask, like when you are going from your office to your house, is there any bar on your way or any beverage shop on your way? They say, yeah, usually I get my bottle from there. So if they are following the same way, when they reach that place, because of the associations, it is highly likely that they will get the craving. So one simple suggestion is you avoid that route for at least for some time, some months. You take a different route so that this craving is not there. Likewise, for friends with whom you have been drinking, you avoid them at least, because this deconditioning can happen over time. So maybe 3 months, 4 months, you avoid such friends. So avoiding is one technique that we can recommend. Another one is rearranging. For example, suppose a person has been drinking always in his bedroom, and even if he has been admitted in your center for a few weeks, he is going back to that room, that same exact room, because of the association, because of the memories. Like again, he may get the craving. So a simple technique that you can suggest them is you simply rearrange, you move the furniture, you change the curtain, you change the calendar. So if you do that, the ability of that room to induce craving because of the classical conditioning will be weakened. Another one is like if they cannot fully avoid, they may not be able to avoid all situations, all persons, their employer, for example, and all. So in such situations, it is better that they learn to cope with such situations. Example one would be a drink refusal that Dr. Barad was referring to. Like one of these friends has already caused a craving in them, and then that person is also offering them alcohol. So how to say no? So there are something called drink refusal skills. I will briefly touch upon them. One is to say no, but it is not like saying a half-hearted no by having a look at what brand they are having, what kind of pickle they are having, and all. It should be in a clear, firm, and unhesitating voice. You have to teach them to tell no. You can even role play that when the patient is admitted in your hospital. You can show to them how exactly they should say no. And after saying no, they should not stop there. They should actually make direct eye contact, like assertiveness he was talking about. Like in an assertive manner, looking at the person's eyes with confidence, the person should be saying no. And after that, one should not be stopping there, because if one stops there, the person may again continue with the same topic. So rather, the patient should change the subject to something else, something that is not alcohol related, so that the person again does not force. Another option is, suppose a friend is calling and saying that I am bored, I have nothing else to do, please give me company to drink. In that case, the patient can offer alternatives. Let us go for a movie, let us go to the beach, things like that, so that the relationship is not affected. At the same time, the lapse does not happen. And this is very important. Like many patients often give excuses. No, today I cannot drink because today my father-in-law is home, things like that. That should never happen, because if that is the excuse, next day the person will again come. That day he will have to think of another lie. So better categorically say that I have stopped because of such and such reasons. Don't force me. Don't like ask me to join you. This kind of drink refusal people should be doing. Now moving on to operant conditioning. Operant conditioning has two roles here. So one is it leads to drinking through certain methods, and also we can use operant conditioning in the treatment also. I will discuss both briefly. How it leads to drinking, it can become, operant conditioning can be a motivation for drinking. It can be a positive reinforcement or a negative reinforcement, and both these can be either in a social domain or a personal domain. I will give you examples, it will be clearer. Positive reinforcement in the social domain would be, for example, to obtain social rewards. For example, some engineers, contractors, etc. If they go to some clubs and drink with people, they may get to know more people, and then they may get more orders, more job, more contracts, etc. These kind of gains they may have. Or it can be simple personal positive reinforcement, simply to enhance the mood, like the way most of us drink during the conference evenings and all. Though already that positive mood is there, but just to enhance, improve the quality of that atmosphere. Then it can be also negative reinforcement, again, in the social or personal domain. In the social domain, for example, to avoid social rejection. For example, suppose there is a party in an office or in a hostel and the person does not want to drink, but he may feel left out, he may be ridiculed, he may feel bored alone. So to avoid that, he joins the group and he drinks. Or it could be personal, dealing with negative emotions. I will come to that. So like if these are all these four reasons, if they are leading to occasional drinking in a person who does not have alcoholism, that is absolutely fine. But a person who has alcoholism, if the person is lapsing or relapsing repeatedly because of these reasons, then we have to teach them the alternatives, especially like this social rewards group. For them, you have to, especially one technique that helps is that decision box, where you help them list the pros and cons of doing that. And also, like for those who are doing it to enhance positive mood or to avoid social rejection, they will have to be taught about alternative methods of enjoying pleasure, alternative hobbies, other hobby, music listening, etc., etc. We will discuss later also that part. So basically here you have to teach them alternatives. Now this fourth group, that where they're trying to deal with negative emotions, that is a slightly different group compared to all other alcoholism patients, because most of them, they may have a depression, anxiety. One of my patients actually had migraine and he was drinking as a self-medication. I just gave him some migraine prophylactic agent and his alcoholism stopped. So for those people, whatever underlying reason is there, that you have to try to find out and treat, so that this negative reinforcement is taken care of. And this negative emotion part you have to assess in more detail, because there can be some differential diagnosis for that. One is there could be a comorbid depression or anxiety, for which you may have to use the appropriate pharmacotherapy, psychotherapy, etc., etc. Or it may be because of the persisting craving, because the craving is long lasting, and to tackle that they are drinking. So for that, again, you may have to use some anti-craving medications, or like as we will be discussing later also, some of the craving management techniques. Basically that is distraction. Whenever the person is feeling a craving, if he does any other activity, taking bath, listening to music, watching TV, reading something, calling someone, having sex, praying, doing shopping, anything, if he does for 15-30 minutes, the craving will usually go away. So these kind of techniques you have to teach them. Or it can even be part of a protracted withdrawal, the negative emotions, especially if it lasts more than 1 month, 2 months, and all. It may be, so like many of you may know, like acamprosate is effective in that protracted withdrawal with depressive features. Acamprosate is found to be an effective agent, so you can use that there. Or for these negative emotions, you can use all the usual techniques that we use for patients with mild depression, dysthymia, and all. You can psychoeducate them, saying that like occasional fluctuations in mood, anger, sadness, anxiety, etc., are part of normal human life. You can ask them, as I told you earlier, to increasingly do perform pleasurable activities like other hobbies, sports, and all. Then if there are these depressogenic cognitions, we can do the kind of CBT that we usually do for depression. Anger management can be taught, sleep hygiene techniques can be taught, relaxation techniques can be taught. So all these will help them like escape their negative emotions, so that they don't have to drink as a part of self-medication. Now, another aspect, especially when we are, like I told you about this tackling negative emotions and all, many of them start drinking from a very small age. And alcohol is the only solution they have for everything, be it for anxiety, be it for enjoyment, be it for celebrations, be it for grief, anything. So they may not have many skills to deal with anything. So all these people, they may have to be taught a lot of skills in various domains. And this is one wonderful book which we have been using in our unit for past about 10 years. It is by Mondi et al., Treating Alcohol Dependence, a Coping Skills Training Guide. Drink refusal, developing new friendships, developing new hobbies, all these kind of things they have very beautifully given. So any of you who are interested, you can go through this book and learn how to teach these patients the coping skills, so that they don't relapse again. Now, I told you earlier that operant principles we can also use in the management also as a form of behavior therapy also. For example, especially for adolescents, if they are willing to come for a session, there can be some kind of incentives from the parents. Or if there is an sobriety for the patient has not had alcohol for 6 months, 1 year, 2 years, and all, then the parents or the family can give some appropriate rewards depending on their financial status and all. That would be a motivation for them to maintain the sobriety and not relapse. Also, likewise, suppose there can be the use of negative punishment. Suppose if a person lapses, then maybe the family can withdraw paying attention to the person, stop talking to the person for some time and all. And as is always the case when we talk about behavior therapy, there are certain basic principles, like it should be consistent, it should be immediate, everybody should be involved from the family. All these kind of principles are relevant here also. So we discussed about the classical conditioning part and the operant conditioning part. Now moving on to the more detailed part of cognitive mediation in alcoholism. What kind of cognitions can lead to relapse in alcoholism and how we can tackle that. The kind of thoughts that can lead to drinking, lapse or relapse are basically of 4 types: positive beliefs, permissive beliefs, uncontrollability beliefs, metacognitive beliefs. We will discuss each of them. Positive beliefs, as the name implies, basically means if I drink, then I will have this particular positive effect. That can be a result of like what we already discussed, a classical conditioning or operant conditioning. For example, a person will feel that if I cross that street and if I get craving and if I drink, then I will be able to escape from that craving. Or if I go and drink with that person, he may give me some order and my business will improve. So this kind of positive beliefs can result from classical and operant conditioning. Then there are permissive beliefs. Permissive beliefs happen later. Permissive beliefs appear when the person already has some craving. Then these permissive beliefs appear and reduce the person's ability to tolerate the craving, so that he goes and drinks. His ability to resist the craving is weakened. There are 2-3 kinds of permissive beliefs. One is entitlement. An example would be the person may think that I have been sober for 6 months now. I deserve to drink. I have been working hard throughout the day, so it is okay if I drink in the evening. Minimization may be that they may minimize the harm that can be caused by alcohol. Now that I haven't had alcohol for 3 months, my liver may have improved. So even if I drink now, nothing great is going to happen. These kind of thoughts can be there. Or it could be justification. Justification in the sense that everybody else is drinking. Doctors will anyway say that one should not drink. Anyway, I am going to die one day. All these kind of justification thoughts can also be permissive beliefs. Then after positive and permissive beliefs, we have uncontrollability beliefs. They can be of 2 types. One is about the uncontrollability of craving, then about the uncontrollability of drinking. Basically, the person believes that craving is something that I can never control, or drinking is something that I can never control. Many patients may hold this belief. Craving is a physical reaction, so I cannot do anything about it. They may equate it with, say, hunger or thirst. I usually speak to my patients like this. Like when we feel hunger, unless we eat something, the hunger will keep on increasing. It will never go away on its own. Likewise for thirst. But craving is not like that. When you are feeling craving, be it for smoking, be it for alcohol, even if you don't use the substance, after some time the craving will gradually dissipate. And with every subsequent occurrence, it will be less severe and it will be less long lasting, it will be shorter. So this kind of education, if you give them, then they may know that they don't have to drink whenever they feel a craving. Likewise, they may think that my drinking will persist no matter what I do. Especially this happens after a lapse. They have not had alcohol for about maybe 2 months. Then they drink once at a party. Then the guilt sets in. Oh, no, I will never be able to control my drinking. And that leads to negative emotions, guilt. And because of that, the next day they again drink. So that is uncontrollability beliefs. Now coming to the final one, the metacognitive beliefs. Metacognitive beliefs is basically what the person thinks about how the alcohol affects their cognitive abilities. And that can be of 2 types, positive or negative. The alcohol can help my my cognitive abilities, or the alcohol can worsen my cognitive abilities. Actually, both can lead to drinking. Examples of positive metacognitive beliefs could include there could be patients who believe that if they drink alcohol, they will be able to solve problems better, they will be able to control their thoughts better, they will be able to regulate their attention better, they will be able to regulate their emotions better, and all. These are all common thoughts. All of you know, all of us keep seeing alcoholism patients on a daily basis. So if a patient has any belief like this, what happens is they will use alcohol as a coping strategy. Whenever they have to solve a problem, whenever they are feeling sad, anxious, they use alcohol as a coping strategy, and that is not good. Now, negative metacognitive beliefs is the other way around. They may think that like alcohol has destroyed my executive control, my ability to control my alcohol, my drinking. Or they may feel that alcohol has affected my other cognitive abilities, like ability to manage craving, ability to make good decisions, etc., etc. But you may feel that if a person has thoughts like these, they may actually prevent them from drinking. But it is not actually what happens. What happens is these thoughts come when they are under the influence of alcohol, especially after a gap, they have a lapse, they drink, then these thoughts set in, these negative metacognitive beliefs. So I had again, that means my ability to control drinking has been lost forever, I will never be able to stop, my mind has been damaged, my intelligence has been damaged. All these kind of thoughts set in, that leads to negative emotional states like guilt, depression, anxiety, that leads to further drinking. Basically that becomes a vicious cycle. So that is also bad. So we told about positive beliefs, permissive beliefs, uncontrollability beliefs, and metacognitive beliefs. These four kinds of beliefs can lead to lapse or relapse in alcoholism patients. Now, we discussed about various aspects, this conditioning, these beliefs, everything. All these have been unified into one single model of a cognitive model of relapse. Why relapse happens? I will explain that first, then we will discuss how we can clinically use that. First, as Dr. Bharat was saying, there will be some stressor, some activating stimulus. It could be a party, it could be seeing somebody drinking in a TV, it could be some friend coming from abroad with a bottle, etc., etc. Thus, activating stimulus will be there. That will lead to positive beliefs. If I drink, then I will be able to feel happy, I will be able to sleep, I will be able to enjoy the party better, etc., etc. That leads to some automatic thoughts, as in depression. Go for it, have a drink. That kind of automatic thoughts can be there, and that leads to craving. And craving, as I told, when craving is there, the person may try to resist that, but that ability to resist is weakened because of the permissive beliefs, that minimization, justification, entitlement, and all. And when that happens, the person takes behavioral steps that lead to drinking, like he may go and buy alcohol, or he may ring up a auto driver and ask to bring a bottle, etc., etc., and he may drink. And once he drinks, that alcohol itself can act as the activating stimulus, and again the cycle may repeat. So this also can become a vicious cycle. So that is one cognitive model of relapse. Now, what to do about this? So to do interventions, like all of you know about that functional analysis and all that we usually do for therapies. Here also we have to assess the relapse first, so that we can choose the appropriate interventions and implement them. So assessing the relapse, this is the kind of table. All of you know, whenever you do CBT, there will be tables like this. I won't make it very complicated. And once you have some experience, you can do this without help of tables also. So here what happens is there are 5 items that we are assessing. One is, what is the stimulus, like the activating stimulus that we already discussed, that led to the series of events. Then the next is, what effect this stimulus had on this particular person. Then how this person responded to that. Then what were the consequences that led to drinking on that particular day? And then what are the consequences that led to continuation of the drinking on the subsequent days? I will give you 2 clinical examples, then it will be very clear, all these 5. And all these 5 have to be assessed on 5 domains: environmental, cognitive, physiological, behavioral, emotional. There's so much of theory, so let us focus on 2 examples. So this is a story that you may be highly likely to hear when in your clinic. There is a patient who hasn't had alcohol for 4 months. Then one day he heard that some of his friends are having a get together in a nearby bar, and they call him. So he thinks that I have anyway stopped for 4 months. Now I have the ability to control. I will not drink. I will go there and sit with them and give them company and listen to their stories. He goes there, sits there, the party progresses, people are drunk, intoxicated, they are enjoying, and he gradually starts feeling bored, singled out, and he gets the craving. Then he feels, okay, I will have one. This is a common, at least in my setting, this is a very common event. So if that happens, like that table that we were discussing, how we will be feeling this? So the stimulus here is what? The environmental stimulus is that the person is in a pub. And the cognitive stimulus is that like once the friends have started drinking, I feel awkward talking to people. I am like sober and they are all drunk, so I don't feel like talking to them. I am not able to talk to them. And the emotional stimulus is the social discomfort that he is feeling. Now, what are the effects these have on the person? He gets a thought that a drink will make me feel better, right? Because he is feeling awkward now. And physiologically, he starts getting craving. And what is the response that he takes? He drinks. Now, what are the maintaining consequences? The consequences that lead to him drinking throughout that evening? Because all these go away, these thoughts, the distraction from the original thoughts that I feel awkward, all these kind of thoughts go away, the craving goes away, the emotional discomfort, that the social discomfort he was feeling goes away. So because of that, evening he keeps drinking. And what happens the next day? Next day he is have this guilt setting in. My drinking is out of control. I will never be able to stop. And because of that, like there is an escalation of negative emotion, depression, guilt, anxiety, self-blame, and all. And because of that, that lapse proceeds to a relapse. Now, this table is not just for like a filling. We get clues from that, what we have to do, where we can intervene. Now I will be showing it with each of the items. Like first he was in the pub. So earlier when we were discussing that classical conditioning, we told about the stimulus control. So he should have been told already, or maybe told now at least, being in a pub, because of these associations, because of this conditioning, you will get the craving. So you should avoid being in such places. Then if he is feeling social awkwardness, it is not that easy once you are with friends who are drinking to apply some interpersonal skills and still remain sober there. But if the person reveals to have such skills, then you can teach them some interpersonal communication skills and which they can use in such situations. Then for these thoughts, drink will make me feel better. For all them, we will use cognitive restructuring, which we will be discussing in the coming slides. For craving, as I told earlier, any distraction strategy he could have used. For drinking, especially like if one of the friends was forcing him, encouraging him to have a drink, the drink refusal skills that we discussed earlier, he could have used that. And for these thoughts, he could have used cognitive restructuring that will be discussing later. For managing the negative emotion, we already discussed how to manage relaxation. A lot of techniques we discussed. He could have used one of them. So from an assessment like this, we get the target points, like the symptoms that we can target for further intervention, so that further relapses are prevented. Here is another example. This is a patient again who has been abstinent for many months. Now it is a Sunday. He is alone at home. There is nobody there. The family is somewhere. There is nothing active going on in the OTT platforms or in the TV, and he is very bored. And out of the boredom, he starts getting the craving. And in the fridge, there is some bottle kept for some guest who is expected. And he goes and drinks that. So for a patient like that, what would be this box? The stimulus is being at home alone, and cognitive stimulus is I feel very low, and emotional stimulus is the negative emotion that results out of the boredom. And what effects these have on the person? If I drink, that will make me feel better. All this boredom, all this low feeling will go away. And what is the effect? What is the physiological effect this has on the person? He starts getting the craving. And what is the action he takes? What is the response? He drinks. And what are the maintaining consequences for the day? Again, as in the previous case, distractions from the original thoughts about feeling low and all. the craving goes away, the negative emotions goes away. So because of that, that evening he drinks. And the next day, again, as in the previous case, the thought set in, I am an alcoholic, and the negative emotions escalate and he drinks again. So this is how we assess. And here also we can like target, like we can find what are the points that we can target. Being at home alone, scheduling alternate activities. I told you about that skills book, they talk about that. Like the person should plan in advance. If he is going to be alone at home in a Sunday evening, there is a possibility that this is going to happen. So he should have in advance planned some other activity, so that this boredom, everything was like prevented at the first place. Now this is very important, because when people are having active alcoholism, they spend a lot of time waiting for the shops to open, purchasing the alcohol, drinking the alcohol, recovering from its effects and all. A lot of time is spent on that. So once they stop drinking, all this time is there with them. They don't know what to do with that. So as therapists, when they are with you, you have to discuss with them and help them find some activities, alternative activities that will give them feelings of mastery, feelings of pleasure, enjoyment, happiness and all. Otherwise, all these negative emotions will be there, and as happened in this previous patient, out of boredom, they may lapse. So this is an important part of your managing, especially patients who are relapsing repeatedly. So in this patient, as I told, one is the avoiding that scheduling alternative activities and avoiding that sitting alone on a Sunday evening at the home alone. Then the negative emotion, the way we discussed relaxation, alternative activities, all this could have been done. Cognitive restructuring for these thoughts, distraction strategies as we discussed for the craving, cognitive restructuring, managing negative emotions, all as in the previous case. So this is basically how we assess a relapse and find points for interventions and do the interventions, so that such instances do not happen in the future. Now, how to do the cognitive restructuring? All of you know about depression, right? It is more simple. You find the negative thought, you find the alternate thought, you measure the strength of the belief and all. This is almost similar only. First, we will discuss about the permissive beliefs. Permissive beliefs are, as I told you earlier, when the person is having a craving, thoughts that reduce his guard, let him reduce his guard and have the alcohol. So this is the kind of table that we have. We will again discuss that with the help of an example. The first thing is, as we already discussed, the activating event, the stressor, as our chairperson put it, what led to the series of events, that what we have to assess. Then we have to assess the feelings and sensations. That is basically the craving only. For example, in anger management, we ask for the warning signs, right? Like that, because before drinking, when they have the craving, what exact changes they have in their mind and body, that we have to assess, so that we can help them identify that now I am having a craving. Then we have to identify their permissive beliefs. Then, as we usually do in CBT, we have to help them find some evidence that does not support the belief. We have to help them find some alternative beliefs, and then assess the strength in the alternative beliefs. Let me show you a clinical example. Here is another patient who went for a walk without much aim in an evening along a riverside. Then he saw an alcohol shop. He thought that I have only a small amount of money. Even if I drink, it will be a small amount. Nothing will happen. From tomorrow, I will again not drink. And he goes there and drinks. And after a few days, he ends up in your clinic. So for a patient like this, how we will be filling that table? The first, as I told you, is activating event. So to find that out, you have to ask some questions. When did it happen? Where were you? What were you doing? What were you thinking about? All these kind of questions will give you leads about what exactly led to this incident. Then the feelings and sensations. So here in this case, we will get the answers like, I was walking by the river, I saw a liquor shop and experienced a strong desire to drink. I stopped and had one. This is the answer that the patient gave. The next is the feelings and sensations. As I told you, the craving. So the question you can ask is, what feelings and body sensations did you notice at the time? So that in the future he can recognize when he gets craving. So this patient said, I felt bored, frustrated, worried, and I was also slightly elated from the possibility of having a drink. So that was his manifestations of craving, right? Now, next you have to find out the permissive beliefs. That means, what were you saying to yourself? that made it easier to keep drinking. उस वक्त आपने अपने आप को क्या समझा रहा था और क्या सोच रहा था ताकि आप उस समय दोबारा शुरू करने का फैसला लिया काफी आसानी से, वो कैसे आसान बन गया वो फैसला करना. This kind of questions you can ask so that what permissive belief went through the patient's mind that you can understand. In this patient's case, what he told was, I have only 200 rupees, so I can't do too much damage. I can start afresh tomorrow. These were his permissive beliefs that led him to drink. Now we have to help him realize that this is not a good thought, not a thought with basis. That is a harmful thought, as we usually do in CBT. So we have to help them find out some evidence not supporting the beliefs. All of you know about the basic CBT principles. So we will be here using something like a Socratic questioning. We will ask them some questions so that they themselves will come out with some evidence not supporting these beliefs. For example, you can use some counter questions like, what would someone else say about these beliefs? Suppose that time you called your friend and told, I am standing outside a bar near the river. I have only 200 rupees and I am going to go inside and have only for 200 rupees. What they would have answered? These kind of questions you can ask. Or it could be the other way around. What would you say to someone else? If one of your friends called you and told, I have only 200, I am entering the bar, what you would have told them? So in this case, the patient told that, okay, it was not a right decision because in the past I had entered the bar, but there I had met my friends and I had borrowed money from them. And also during my 10-week sleep period earlier, that time also I had thought like I will be able to control, I will be drinking for 200 rupees only, but I had ended up buying money or saying them that I will pay later and drinking again and like finding it difficult to stop. This kind of evidence not supporting the beliefs the patient says. So now what are the alternative valid beliefs? You help the patient find them out so that next time they can remind themselves of these alternative beliefs. Whatever more helpful belief you should have had that time, you ask that. Then in this case, the patient finally came out with these statements. I can borrow money. Even if I have only 200 rupees with me, I would be strengthening a tendency to drink when feeling bad or bored. Like even if I drink for only 200 rupees, even then, what I am doing is I am teaching myself that whenever I feel bored, I can have a small amount. That is not a good learning for somebody who has relapsed a lot of time. So this is like from this entire exercise, the patient learned that this was the cognitive error that he made. And how much he believes in this new belief, the strength of the alternative beliefs, that you have to ask. And as we usually do in CBT, the person says 90%. So now he know. The next time, most likely he will not make the same mistake. Before entering the bar like this, he will remind himself that I can borrow money and I can tell them that I will pay later and I will lose control. So that is how you help them prevent another similar relapse. So likewise, you can do for positive beliefs also. I won't go into the details because of time constraints. And then the uncontrollability beliefs. I told earlier about craving and drinking. Craving I will discuss. For example, this is the kind of table that you can use. Craving belief, strength of belief, evidence for and against. Let me see the example. Let me show you the examples. The craving belief the patient has is that, like the patient had severe craving and he had alcohol. Because of the belief that I will go mad if I ignore the craving. Because of that, the patient had alcohol. So you ask the patient how much you believe in that. How true is that on a scale of 0 to 100? The patient says 90%. So now you have to help them assess this thought, whether it is indeed 90% true. So you help them assess the evidence for and against this particular belief. So what is the evidence for this belief? I feel intense anxiety with the craving. Whenever I feel craving, I feel intense anxiety. So I feel that if I don't drink, the anxiety will increase and I may go mad. That is the patient's explanation. Now, is there any evidence against this? After discussion with the patient, it becomes clear that the craving and anxiety had gradually dissipated on several occasions, even when I did not drink. So that is the evidence against. So now when the patient compares both the evidence for and against, what is the outcome? The patient realizes that the initial concern is baseless. Now you can rewrite the belief in each thought. Then they may say that this 90% may by now become 5% or 10%. That is how you tackle the uncontrollability beliefs. I will discuss two more concepts very briefly. One is SID, seemingly irrelevant decisions. What that means is the patient takes a decision which outright may not feel that it may lead to drinking. but ultimately ends up in him drinking. Let me show you an example. We have a patient who is working in an office. He does not have much job in the afternoon. He is bored. And also recently he had found out that his ex-girlfriend has a new partner. So he was upset about that. So he thought, okay, I will not sit in the office here. It is boring here. I will just roam around the streets. He walks through the streets and as expected, he ends up in a bar and drinks. So this was an SID. We will see how it is an SID. So what kind of like a table we can use to assess such a lapse? As in the previous tables, what is the preceding event? So here the patient says that it was early evening. I was working poorly. I felt low and frustrated. And I had recently found out that my ex-girlfriend has a new partner. So what was the seemingly irrelevant decision that the person took in this particular case? The decision was to aimlessly walk around the town on his own, because he should have like foreseen, he should have thought that if I do that, I may end up in front of a bar, or I may meet a guy, a friend who drinks, and I may end up drinking. That he should have foreseen. So that is the SID that he made here. So what could have been done differently? Now, retrospectively, you are helping him think so that in the future he can avoid such errors. So what could have been done? He himself says, I could have engaged in an activity that would have given me pleasure and felt I had mastery of. So what would have been the advantage of doing things differently? It would have taken my mind off my girlfriend and improved my mood. And what would have been the disadvantage of doing things differently? Nothing. So what could have been a safe alternative rather than walking aimlessly in the town? So like he himself says, I could have gone for a movie, or I could have gone running and all. So that is an SID, a seemingly irrelevant decision. So basically the patient did not go out with the plan of drinking, but he took such a decision which indirectly down the line end up in him drinking. So what kind of suggestions you can give the patient? All alcoholism patients, whenever they are making a decision, that is not an everyday decision, something new, they have to consider all the options, all the options for the possibility which path can lead me to drinking, and think ahead to the possible outcomes of each option, and then select one of the options, and the best way is choose the way that is like the least likely to lead to drinking. And if they are choosing a risky option, at least they should ensure that they have a protective plan. Like if I end up in front of a bar, I will use craving management technique. If I meet a friend, then I will use drink refusal techniques. These kind of strong plans they should have in mind. If they are choosing a risky option, it is best to avoid choosing a risky option. Finally, about abstinence violation effect. This is what leads to what makes most of the lapses and become finally a relapse. What happens is, we alluded to it earlier also. Once a patient has a lapse, he drinks once. That leads to a lot of negative emotions and lot of negative cognitions. He have had one drink, but he starts thinking, I am stupid. My family paid so much for the previous de-addiction treatment. I will never be able to do for my kids what a father is supposed to do, etc., etc., etc. And because of that, a lot of guilt, self-blame, low mood, anxiety, insomnia, everything sets in. And to manage that, the next day he goes and drinks. So if this is the case, again, the same cognitive restructuring, managing negative emotions, etc., that we discussed earlier, those techniques have to be used. So summarizing what I told in the previous slides, basically I told that classical conditioning can lead to lapse and relapse because of the associations with the internal stimuli or external stimuli. So that can be managed by avoiding the stimuli altogether, or restructuring the room, or maybe coping, drink refusal, etc. Operant conditioning can be the positive reinforcement, negative reinforcement, and positive reinforcement can be used for people who are sober. Negative reinforcement can be used, sorry, negative punishment can be used when somebody goes and drinks and all. And all these four kinds of thoughts: positive beliefs, if I drink I will have this benefit; permissive belief, when I have craving, like minimization, justification, all these kind of thoughts can be there. People can have a feeling that I cannot control my craving, I cannot control my drinking. Then there can be positive or negative metacognitive beliefs, and all these can lead to that formulation, this When a stimulus is there, the positive beliefs come first, the automatic thoughts come, craving comes, permissive beliefs comes, behavioral steps come, and he drinks, and that becomes a vicious cycle. So we have to assess an incident like that using these headings. What was the stimulus? What effect that had on the person? What responses the person took? And what were the consequences that led him to keep drinking that day? What led him to keep drinking the next day? That has to be done on environmental, cognitive, physiological, behavioral, emotional domains. And then it does not end there. As we discussed in the previous slides, we have to intervene. We have to give them suggestions for the future so that this is not repeated again in the future. Thank you. I will stop sharing the screen.
Thank you, Saul boss.
Thank you, Dr.
Wonderful
Saul.
listening to you. So
Yeah.
we'll start. Sir, chairpersons for your comments. Then we'll go for the question answer sessions.
Yeah. First
Yeah.
of all, thank you very much, Dr. Saul Amin, for their wonderful and brainstorming session. Now the session is open for question answer. But before open, I have some question. That question will reply or answer by Dr. Saul Amin. That is, sir, one question is there protected withdrawal in the alcohol dependent patient or alcoholism? I have till date I know only the opioid dependent patient.
Opioid. No, in alcoholism also, in some patients it can be, especially if you read about acamprosate, you can say that. Like in some patients, the protracted withdrawal can persist, especially some dysthymia kind of picture can persist. And actually, acamprosate is indicated for that. In various textbooks, it is mentioned. So it is not essential that you give acamprosate. You can use other methods also, like the other techniques that I mentioned. But it is there. It is not very common, but it is there. It is mentioned.
So like lethargy, low mood, or insomnia, sexual dysfunction is also the symptoms of protected withdrawal in alcohol-dependent patient?
That I am not very sure. That can be a complication of alcoholism, chronic alcoholism. It can be even a complication of your disulfiram or something. I don't think sexual dysfunction is a part of protracted withdrawal. That is more of emotional symptoms as far as I remember.
Second one, sir, what is difference between the relief craving and reward craving?
I am not very familiar with these terms, to be sure.
Positive reinforcement versus negative reinforcement.
Okay. Now I can explain. Suppose somebody is having headache and he wants a relief from that, he drinks. Then that is relief craving, right, Amrit? And maybe somebody, yes, Amrit.
Yes, sir. Please continue.
Exactly. That is what. So there are actually various authors use various terms. I don't think this particular term is used in this book.
Amit sir, but the treatment modality is the changes in the relapse prevention. Yes. When we use the basket of relapse prevention drugs, either we use the acamprosate or naltrexone or like topiramate. And if we see there is relief craving, then we have the option, and reward craving, we have the another option.
No, as I said, like if this protracted withdrawal symptoms are there, then acamprosate is the better. And if there are depressive symptoms, anger issues, then appropriate pharmacotherapy has to be done. But practically in my patients I see in Kerala, only disulfiram works, nothing else works. Okay. Theory books say many things, but this is like medication wise. This is my experience. Only thing is, like when the person has any CAD, coronary artery disease, then I don't give disulfiram. Though I take the consent for disulfiram and then I gave baclofen. Other than that, no other agent I have seen to be working in these patients that come to me.
Thank you, sir. Dr. Suresh Kumar.
I drink the control amount of alcohol.
Yeah. Many questions from the chat box, sir. I should can answer because we are running short of time.
I'll take the question, sir. I'll take the question, sir, if you permit me.
Please, sir.
Shaul boss will be short and sweet. So CBT must be most effective for those people who have very logical bent of mind and those who are committed to the hard work it required. For this, that do not share these trends, what strategy is recommended to ensure CBT works for them? Those who are not hardworking like me or somebody who are not very committed. or logical, they're not very
No,
sophisticated.
no. One thing is motivation has to be there. If the person is, say, pre-contemplation, then you cannot do any CBT. For them, you have to do motivation interviewing. Only once the person is motivation, these are going to work. Then all of us talk about this cognitive sophistication. Only then we can do psychotherapy. Nothing like that. If a person has been able to drink for years, find money for that, he will be able to understand whatever simple principles that we discussed today. We did not discuss any complex ideas. No, everything was simple, practical techniques. This you can use with any Indian. I don't think a person has to be highly logical or something like that to understand the kind of principles that we discussed today. What
So
was the other
generally,
question?
Generally, how many sessions, sir? So one was psychological sophistication, and one was if somebody is not very hardworking, somebody is not ready to burn the midnight oil or whatever daytime oil to get.
Like they don't want to discuss these things with you, like what thought went through my mind and what I was doing, things like that. That is the question. Then what to do?
Yes, sir. No, if somebody does not have the logical bent of mind and somebody is not committed. So not committed, you talked about motivation. And if somebody does not have a logical bent of mind.
That is what I told. These kind of things does not need that kind of a logical bent of mind. If somebody has been able to find money enough to drink for so many years, they have sufficient logic to find alcohol for so many years. This kind of that is what I told. Now what we discussed is all very simple tips. So almost all of them should be able to do. Even your villagers, farmers, everybody should be able to understand whatever tips I told today. That is what I feel.
Sir, how many sessions are required generally to get?
That depends actually, depending on like how complicated the situation is, how many factors are involved, whether it is IP, OP and all. Usually I don't call them separately for CBTs and all. Whenever they come, especially with the labs, I sit with them maybe 15 minutes, 30 minutes. That particular labs I discuss with them. That's all. And if it is an inpatient, then I will discuss with them with their past lapses also. That will take, because I will have more sessions with me. I will be seeing them every day. So there are a lot of other, like in the beginning I told, no, we are all clinicians, so I am not going by manual based things like that. Practical terms I am talking about. If there are any clinical psychologists experience, they can answer exactly how many sessions will be needed and all. But for us practicing psychiatrists who are busy clinicians who don't have a lot of time, so we can integrate that into the routine follow-up visits, these kind of questions, these kind of tips that we can integrate into the usual OP visits that last maybe 15 to 20 minutes. You can do that.
Sir, how does the alcoholic anonymous model compare with the CBT model, the topic of today?
I am not very familiar with the AA model, but I don't think they are against any of the principles of CBT. That is my understanding. I am not I have attended AA meetings, but I haven't gone through their literature and all. I am not an expert in their this thing. So I cannot compare between the two.
Sir, does similar principles apply for binge pattern also?
Binge pattern, this is more important because binge pattern people are the ones who have frequent relapses. No. So for them, this is more important. How the binge happens, how each episode happens. So for binge pattern, this is more important than for somebody who has continuous kind of a drinking.
So what is the success rate generally?
Success rate, again, as the chairperson initially told, like I personally don't have data as such. And also the success rate, when we are measuring, we should not be talking about the person does not drink ever again. The success rate to me is like I have seen a patient, I have treated, and if he gets a lapse, he comes back to me and he listens to a session, he goes back. Next time when he has a lapse, he comes back to me. That is a success, because that is not we cannot expect anybody to stop drinking for so many years. But if you have sufficient rapport with him, and whenever he drinks for 2 or 3 days, he's coming to you and he is discussing the lapse with you, and you are giving him tips, gradually the interval will keep on increasing. The percentage wise and all that may not be relevant. I don't have the data also, because many patients don't come back to us. And especially I am a single practitioner. I don't have any that kind of statistical meeting kind of things. So exact percentage and all I cannot tell you. I don't know. I don't have.
And sir, how to handle our therapeutic nihilism? Our therapeutic nihilism.
There is no need for therapeutic nihilism. I told you, therapeutic nihilism sets in when your aim is absolute abstinence. You expect that you have treated a patient, he will never drink again. Alcoholism is a chronic illness like hypertension, diabetes, everything. In any diabetic patient, there will be hyperglycemia, hypoglycemia. In any hypertensive patient, there will be days in which BP is high. Likewise, in alcoholism patients, there will be days in which they will drink. So if you look at it that way, there is no scope for therapeutic nihilism. And what I would say is, if the patient has abstained for at least maybe 3 months, 6 months, his brain, his nerves, his liver has got a lot of chance to recover. So even after that, even if he has a short binge, it is absolutely not a failure from the therapist's part. I hope I answered the question.
Yeah. Sir, Zain has asked, due to chronic illness and otherwise, hypofrontality could be there. So the behavioral inhibition is, there is problem in that.
True.
So isn't the patient actually right in believing that he doesn't have much control over the impulsive drinking and alcohol?
No, but our point is that should not lead him to drink more. Because that even if that is right, his reaction to that is not correct. No. What he is seeing is that I have lost my ability fully. Because of that, he is feeling upset and he is drinking again. That need not happen. You can educate such a patient that if you remain abstinent, your capacity will be regained. Your brain, even there are studies, even in some of my presentations, I have the MRIs of brains where after 2 years of abstinence, the brain has actually regrown to some extent. So you can tell the patient, you wait patiently, your brain will recover some of its functions. So you don't use this as an excuse, as a reason to self-medicate with alcohol. That kind of teaching you can give.
Okay, so Dr. Sai Kumar wants to ask, what are the common cognitive distortions or errors you have observed in your practice in incidence and relapse in this topic?
No, like most of them, what happens is this overconfidence, as I told you, like that minimization, justification, those kind of things. Anyway, it has been 6 months already. So even if I drink now, it is now okay. I will be able to control. I have taught myself, proven to everyone that I can stop, that kind of things. So there, I did not mention it in the presentation. Basically, there I also speak to them about the genetic aspects, because most of them have a family history. And because of your genes, you will not be able to have a controlled drinking. That is how most people end up. Though there are lots of people who drink at festivals and stop there. People like you who have a family history will not be able to do that, because your brain, your liver is built in particular way, and it will be like that forever. Even I have written a Malayalam article on genetics of alcoholism. I give that the patient to read, so they understand the concept. So I think I answered the question.
Yes, sir. And how to include the family members in this approach?
In the CBT approach, like as I told, they can use these incentives, positive reinforcement, negative reinforcement. I have an entirely different presentation on basically what family can do but that maybe we can have it in some other time. I was in your
So we'll invite you again then.
Yeah, because like there are things the family can do when the patient is not motivated to come to treatment. When the patient is in treatment, after treatment, there is a lot of things for the family to do. I had made a presentation in one South Zone practitioner CME. We can do it. So you call me after some months, we can do it.
Sure, sir.
And in this context, basically this positive reinforcement and that negative punishment, these kind of things the family can do. And even like they can help the patient find the alternative thoughts and all. Like the CBT, when the alternative thoughts the patient is not able to find himself, the family can be trained and the family can help them find the alternative thoughts.
Okay, suppose, sir, in addition to alcohol use, the patient also has anger issues separately. So how to amalgamate that in the CBT approach?
No, for the anger, you have to tackle on it. I told you about that already. Anger management you have to do. You are using some of the CBT principles. I personally prefer, especially many of my patients have this intermittent explosive disorder, and they respond wonderfully to fluoxetine. That is one approach that I use. Though we teach them about anger management techniques, most of them are not able to implement that at the spur of the moment when they are having the outburst. In those, they know the theory, but in those moments they are not able to use that. For such patients, I have found fluoxetine to do wonders.
So there are many congratulations and calls to get you again on the board.
Thank you. Thanks a lot.
Amrit,
question, if there is comorbidity with bipolarity, A lot of people have this state dependent, or induced. So do you
The voice is breaking for me. What I think is like, if the question is during the manic episode, if a person is bringing CBT, has nothing to do with you do the pharmacotherapy for mania or depression also. Otherwise, in the inter-episodic period, if the person is drinking, then you can use any of these principles. In between, the voice was breaking. If the question was something different, please
Yeah,
repeat
yeah.
your.
John said it. Yeah. So, sir, so what I understand is instead of
you had shared some books.
Mm.
Are the books available, sir?
They are available in Amazon.
Bolo.
Even that CBT book, the second edition is available. That skills book, it is still available. The first edition itself. Wonderful books. Even I have got some new books on related topics, solution focused therapy and all.
Sir,
There are
can you
lots
share
of
the chat box? Chat box.
what the link. It is there already. You have a recording of the video, no? Or maybe I can share the slides. I can share the slides in the chat box.
Sir, slides you can mail to us and we'll share it.
Okay. I will.
Okay.
I will give it to you. I will give the slides to you.
And sir, many people have asked for your contact details. So if your email or contact.
My email you can share, shahulamin@yahoo.com.
Sir, you can type it in the chat box. So
Okay.
We'll contact you directly.
Okay.
I think so. I think there are a few questions, but they're off topic because the topic of today is not medical management. It is more of CBT. So there are a few questions. I think we can take it in some other proper session.
Yeah.
Otherwise, I think we have completed.
Hand it over to your persons. One hand is raised.
One hand is raised.
Dr. Ashok Kumar.
Ashok Kumar, please go ahead. Unmute yourself.
Sir, I have got some different problem. The alcoholism and crimes, they may not be presenting in a psychiatric setting, but in police station setting or in news media setting, alcoholic person killing his own wife and children also. What best psychiatry advises such type of things, especially in lower strata? Laborers and police daily drinking people, beating family members, beating children. There are so many problems with chronic alcoholism in the labor. Can psychiatry take up such things? How can we approach as psychiatrists rather than whether any public these things? Because government is allowing cheap liquor for the laborers, and drinking may not be problem, but the thing is chronic drinkers harassing family members and family members killing that person, we are seeing daily. Any answer we can, as from psychiatry side, we can give, sir?
Okay. Earlier somebody was talking about therapeutic nihilism. When there is like comorbid ASPD, I think therapeutic nihilism can be allowed, because all these CBT, nothing is going to work if there is comorbid, especially ASPD. And many of the kind of patients that you described, they may be having that. Other than that, if all the assault they are doing, all the harm they are doing, if it is under the influence of alcohol, only when under the influence of alcohol, in that case, proper treatment for alcoholism, including disulfiram and this CBT, everything should be able to help. And as you hinted at, the policy level decisions availability, that is not within our hands. Availability, that is up to the government to decide.
Okay. So, sir, as a psychiatrist, I think what we should take away from it is not a very separate thing. It is one of the tools that we should have. And while we are talking with the patients, if we follow these principles, our talk and our outcome is more favorable. Is it so, sir?
Yes.
Okay.
And as I told you, the aim should not be complete abstinence, never drinks. That is not the thing. The aim should be when the person has a lapse, he comes back to you, so that immediately you can help him, help that from progressing to a relapse, and also help him not repeat the same mistake again.
So that rapport bridge is always there. It is never broken.
Yeah.
Okay. Over to chairperson, sir.
Yes, sir.
Please, sir.
It is a very good and a very nice presentation. The way the slides are, it is a very good and a very attractive, and audience are very attentive. The way do justice to the topic, as usual, the Sahul Amin did his best. I think all the ways the alcohol is not an easy task for day in and day out. What we are doing, we are many patients having lapses and relapses very common. The patient usually they won't come with one lapse. Usually they comes with unless they become relapse for many times, and the people are. It has a, of course, it is a genetic influence or family influence or marital disharmony or financial or cultural, and as usual, social isolation, and there is a boredom. And nowadays, in the COVID and all these situations, they have the people have a lot of stress they're experiencing. These are the very common, the easy way of a solution to take an alcohol, as if it is a solution for all. That is, I don't think the CBT has nicely illustrated. For this purpose, in addition to the pharmacological have the good role, the combined approach is better. I think the Shahul have done the job is in a fantastic way. I think over to the organizers. Thank you.
Tufan, sir.
Dr. Barad is not there.
No, I think he has just dropped out.
Okay. Dr. Sahul, your presentation was fantastic. That must have helped a lot of people. To the best of my comprehension, we have been told that across our clinician's table, how much we can do without depending on a clinical psychologist to give CBT referring, whatever we're interacting with the patient, there are so many avenues. Just integrate this understanding and approach, it will amount to CBT, and over time it will help the patient. But simultaneously, the question raised by Dr. Ashok about the police and criminal involvement, that has to be set aside, because that cannot be part to be done across the clinician's table. We can be aware and try to alleviate the tension. And a lot of family education is also important, because we are going with a blanket. We cannot go with a blanket assumption that all the family members will be cooperative. There may be antagonistic family members for the reason. And at times, Siam also, at times, the cultural determination will confuse it with genetic determination. Put in place. You take particular culture where drinking is the habit. Sometimes it becomes excessive. We cannot tell that it runs in their families, because it runs in the culture. So this has to be taken into account, but it's an excellent presentation. Personally, I feel enlightened, because how to use it across the table, it is more important. At times we think I must have a clinical psychologist to support and cater to my set of beliefs. At times it takes longer for me to interact with clinical. I tell you what you have told, you tell me, then you make a plan and show it to me, then only execute. Other do it in yourself. But here it is not required. You have to just polish your approach with the patient. If you are spending 5 minutes, you spend 10 minutes, 10 minutes. Very excellent presentation. Congratulations, Dr. Fantastic.
Thanks, sir. Thanks a lot. Thank you. Thanks for the opportunity.
A great
So on behalf of IPS Odisha State Branch, I would like to thank my dear senior and my teachers. I'll tell Dr. Shaul Amin.
I sincerely congratulate all the team. Webinar Thursday Musings is uninterrupted, unbeaten. 111 series is still continuous, and I hope it is very useful, enlightening, and I hope all the Tufan Pati, the organizing chairman, and the Alim
Thank
Siddiq.
Thank you.
It is a wonderful topic, and you are very useful. Though you are facing a lot of hard work and hardships, the way you are finding the chairpersons or speakers and all, it is not an easy task. That way you are doing every week. I really am thankful to my wholehearted thankfulness for three of you. It is a wonderful job you are doing. I sincerely appreciate your effort. I think it still go on. Thank you.
Thank you, sir. You have answered. You have thanked a lot of people. I would also like to thank people who are always joining us today. We had more than 350 logins,
Yes,
peak
sir.
of 270, and that is absolutely wonderful. A topic. So thanks everybody, and we would also like to give a thanks to current people who have been supporting us. Thank you, IPS Odisha State Branch, for allowing us to do all these things. Good night. Till another episode of Thursday Musings next week. It will be 112. So Shaul was at the 111 episode. What is that?
Thank you, sir.
111.
Thank you so much.
111. So it's a unique number.
111 not out.
111. So thank you, sir. Good night, everybody.
Okay,
Good night. Good night.
Looking forward to
Thanks
soon.
once again.
Dr. Saul, we may invite you very soon.
Oh, thanks, sir. I'm always willing, sir. Thank you, sir.
We can close the meeting. Hello, Dr. Sidana. Good night. Shreya, can we close the meeting? Thanks everybody who are here till the end after so much time.